I'm Dr. Anthony Cave, a Stanford and Harvard-trained anesthesiologist and integrative medicine specialist. And have you ever wondered what your doctor is thinking when they're talking to you, when they're thinking about whether to prescribe you a medication or to perform surgery on you? There's one number that should be going through their head. And I'm so curious if you have heard it. Let me know below. And actually, there's two numbers, but it's really based off of one. And I want you to know what they are so that you can advocate for yourself and feel comfortable asking your doctor if they know what the number is. So that when they're thinking there, is this the right medication or the right intervention to recommend to you, you can be better equipped to understand if it's the right solution or if maybe it's guided by something else. And I'm not being conspiratorial here at all, but I'm going to show you how that one number can be heavily influenced by money and by many other sources, which might not give you the best care possible. That number is the number needed to treat. And so you understand what it is. Take any medication or any surgery or an intervention, for example. And you can, of course, let me know in the comments if there's any of these that you heard of before. I really want to know your perspective. Based off of that intervention, the number needed to treat what we call the NNT, let's call it 10, for example, in this case, represents the number of people that need to be treated for one person to get the desired benefit or the desired outcome. The NNT, this one number encapsulates a lot. Hey, Connie, you're so welcome. And no, CC, it's not 911, but it is important if you're having a medical emergency. And I don't see anyone here saying that they have heard this before. Hey, thank you for being a member, Polani. Good to see you as well. Denise, you're so welcome. So no one here has heard of the NNT. This is very important. The lower the NNT, the better for you. Because if you go back to our example, if for every 10 patients, one person gets a benefit, if that number was 2, that means for every 2 patients who get this medication, or for every 2 patients who get the surgery, one person gets a benefit. Now, you also have to consider, what are the side effects? Have you ever looked at a medication and been like, there's a lot of scary things back here. What's the chance of them happening to me? Well, the same concept can be turned into the number needed to harm, what we call the NNH. So for example, for a given medication, prescription, surgery, whatever, if an NNH is 10, for every 10 patients treated, 1 patient gets harmed. So you want this number to be very high. This is very important. If you have any questions, let me know in the comments. And I see a lot of people here mentioning the NNT. Greg, it doesn't matter if you're in England or anywhere. This is a common number used in the whole world across medical studies. Wow, and I'm surprised no one here has heard of it. So I'm happy we're talking about it, everyone. Let's look at many examples involving the most common medications out there for conditions like depression, which affect tens of millions of people in the United States alone. So here's one paper here. It's got a lot of writing. I apologize, but I'm highlighting a couple of numbers here. It says for tricyclic antidepressants, the NNT is 9. For SSRIs, or selective serotonin reuptake inhibitors, it's 7, right? So that means for the SSRIs, for every 7 patients who get a prescription, 1 patient will get the desired outcome. The next set of numbers that are highlighted show the number needed to harm. So look at where it is for TCAs, 4 to 30, and then 20 to 90 for SSRIs. So now you got so I see some people here already commenting, PETA Princess, whose name I find hilarious, but I'm sorry that you had, it sounds like a bad reaction to the tricyclics. So even though maybe only 4 to 30 people have to be treated for 1 person to have a benefit, if you're one of those people, 4 to 30 people who get treated get the bad outcome. If you're one of those 4 to 30 people, it doesn't matter how rare it is, it sucks. But that number can help you decide to compare the NNT to the NNH. Now, a lot more examples and ways that these numbers can be manipulated or ways that you can better understand them. So the NNT depends on the severity of the condition. For example, in this study, They look at the NNT for depression, depending on whether it's mild, moderate, severe, or very severe. And look at how the NNT changes based on the severity of the condition. The more severe the depression, the lower the NNT, meaning the more effective the antidepressant. Now, another question you need to ask, who is paying for the studies that calculate the NNT? So here is a recent paper looking at Trintellix called vortioxetine. Very popular, or up and coming, I should say, popular antidepressant. And you can see the NNT was 7, so that's on par with the other antidepressants we've seen in the SSRI classes. And here they say the rate of discontinuation because of an adverse event was 36. So the NNH means that 36 people had to be treated for one person to drop out. So that's actually not too bad. And if you look at broken down by subtypes, if you're looking at nausea, constipation, or vomiting, the NNH actually varies a lot. So 6 people have to be treated for one person to have a nausea side effect. I got to read here, 28 people have to be treated for one person to have a vomiting side effect. So they sound like really good numbers. But I looked up the disclosures on this paper, and lo and behold, I've highlighted that the author of this paper has gotten funding from one of the manufacturers involved in the production of Trintellix or vortioxetine. I'm not saying these answers or these NNHs or NNTs are wrong, but I'm just saying that you got to know where this study comes from and who's paying for it. Point number 2, the placebo matters. The placebo effect is very, very powerful. Very powerful. And you don't have to look at the math here too hard, but suffice to say that if you want to inflate or deflate your NNT, you can just look at your placebo or exclude the placebo. I'm just showing to you that these numbers can be manipulated for good or for bad reasons. Well, hopefully you should never manipulate for good reasons, but that you need to know that many treatments, especially for mental health, have a heavy placebo component. And the more effective your placebo, the less effective your medication looks, and the higher the NNT. So for example, on the top line, you got an NNT of 3, meaning 3 patients have to get the medication for one person to get a benefit. That's actually pretty good compared to 7 that we saw for SSRIs. But if you look at how effective the placebo is, and you subtract 45 from 35, now your NNT goes up to 10. So I hope everyone here is appreciating that these numbers depend on many factors. And just to be clear, ArtChem, NNH, number needed to harm. How many people need to receive an intervention for one person to get harm? So you want that number to be high because you don't want to be suffering from side effects or adverse effects. Very good question. So, thank you to our members. We had in the last couple of days a whole bunch of new members sign up. Thank you so much for your support. Remember that when you are a member, I can see your comments more easily so that I can answer your questions more easily. For those of you who are not members, you get to enjoy everything. But for those of you who do support the channel, I get to see your questions to answer them more easily. Thank you so much for your support. The button is right below in case you want to join. Now, point number 3 is that the severity of the condition matters. You saw for the number needed to treat for depression severity made a big difference. But let's look at something like hip fractures, where hip fractures are horrible. If you know someone who's had a hip fracture, let me know in the comments, because hip fractures can sometimes be a harbinger of demise in the elderly. If we can prevent hip fractures, we hope that we can help minimize premature death. So if vitamin D can help prevent fractures in the elderly, that would be huge. So if you go to the nnt.com, where I got this data here, you can look up all this on your own. For example, here for the number needed to treat for vitamin D for hip fractures, 36, meaning 1 in 36 people treated prevented 1 hip fracture. That can be very powerful. The number needed to harm was 1 in 36 as well. In this, you can see harm was defined as kidney damage. So what that means is that for vitamin D to prevent a fracture, 1 in 36 will have benefit, 1 in 36 will have some element of harm. But because hip fracture is such a potentially lethal event in an elderly person, compared to 1 in 36 chance of I should say 1 out of every 36 people having a harm in the form of kidney damage, likely from the vitamin D increasing calcium levels too high. But that risk benefit is something that oftentimes benefits because a hip fracture is so bad. These are the questions your doctor needs to be thinking of, and you should be discussing with your doctor so that you can make the best choice for yourself. So the next question is the severity of harm. Now, if you look at something like statins given for people who don't have any heart disease. Have you heard of statins? Things like Lipitor or atorvastatin. These are among the most commonly prescribed medications in the United States. So what happens in terms of your number needed to treat? 1 in over 100 to prevent a heart attack or to prevent a stroke. The problem is that it takes 1 in 50 to potentially lead to diabetes as a harm. So while 1 in 100 and versus 1 in 50, diabetes sucks, getting a stroke sucks. How do you weigh these, right? These are the nuances that go into the decision, which is why there is no one right answer for anyone, but you need to know the numbers so that you can make an estimate for yourself. I see Sabrina here is on a statin, and Pamela says that statins aren't a good idea. Well, it depends on the individual. I see Lynn is on simvastatin, and wow, Say is having hip fracture surgery tomorrow. Well, I am wishing you the best for your surgery. I hope everyone here is giving you positive vibes. And Heidi, thank you for reminding everyone to hit the like button if you're learning something new. Let's look at another example about how the numbers have to also reflect reality. What do I mean by this? Blood pressure medications to prevent heart attacks and strokes. So 1 out of 125 individuals who take blood pressure medications can prevent death, whether that's through stroke, whether that's through heart disease. You might think that those numbers are very high, but the number needed to harm is 1 in 10. So reality dictates that if you can prevent that heart attack or stroke, and the risk is 1 out of 10 for, in this case, discontinuing the medication for blood pressure, it's nuanced, but the point is that you got to think about it in the real world. You can't let people walk around with sky-high blood pressures, and any one of those sky-high blood pressures can lead to one of these fatal outcomes. You can't just look at pure numbers. Even though these numbers look similar to the statins, you have to think about in the real, do these numbers represent clinical reality? Discussion you have to have with your doctor. One last point here about how do you define a response to a medication? Let's look at aspirin to prevent a heart attack or stroke. A lot of patients take aspirin. How many people need to take an aspirin to prevent one of these forms of heart disease? It's typically many, many, many people, a number needed to treat. In this set of studies, over 1,000. There's many studies out there that will show different numbers. But compared to the number needed to harm, in this case, they're almost the same. I'm going back and forth here so you can appreciate that having a bleeding event from aspirin is not all that different from having perhaps a heart attack saved. So the severity of saving a heart attack versus the severity of bleeding out, well, that harm is actually kind of on par with what you're hoping to prevent in terms of its lethality. So all I mean to say from this is that you deserve to know what the numbers are. Do they match the reality that you want to live your life in? And does your doctor know when they're deciding what is going through their head, and do they have your best interest in mind? I certainly hope they do, but you can know if you feel empowered to advocate for yourself and ask them, Doc, what are the risks? What are the benefits? For example, when I talk to my patients for ketamine infusions or for the stellate ganglion block, I tell them what my number needed to treat is based on my studies, based on the outside world and in my clinic, and the limitations of those studies. There are many, because they don't all fall into the same types of studies that we talked about here. So there are nuances, but at least your doctor has to have some idea of how many people need to get the treatment for one benefit. I can tell you that for my patients, it's a heck of a lot lower than 7 compared to SSRIs, meaning that far fewer than 7 patients need to receive my treatment for benefit compared to SSRIs, which need 7 patients. I'm happy to talk about that further if you want, but like Lola is saying here, at the very, very least, this should be thought-provoking so that you can get the care that you deserve, because far too many of my patients have been on medications for years and years, and they have no idea if it's helping or not, while the risk of side effects is accumulating. If that's you, please let me know in the comments, because I'm so darn curious about your experience, because doctors need to know the experience of real-life patients and not just look at numbers that may or may not have influence from other entities. Not being conspiratorial, I'm just sharing that reality of doctors and their decisions has to match the reality of their patients. I think that's very reasonable, and I certainly hope you've done that as well. Hey, Arkham, thank you again for that. I've mostly, oh, well, we're not talking about this in this video, T-Care. Let's jump into our live Q&A. If you learned something new, please hit the like button, share what you've learned with others. And I really look forward to learning about your experiences, starting with person. My medicine helps a lot. I wish I didn't need it. I agree. I certainly hope that your doctor is helping reduce the burden of medications so that you don't take excess medications, what we call polypharmacy, because they absolutely have risks and benefits, and sometimes the risks can outweigh the benefits. Spencer talks about a class of medications which has, we believe, a somewhat reasonable number needed to treat in some conditions, but also an incredibly low number needed to harm, meaning you don't need to have a lot of people taking these class of medications for one person to have a bad outcome, whether it be addiction, overdose, etc. Hey, Darian, good to see you as well. Rachel says, they never understand pain. They gave me some after knee replacement, and I got so sick. They ran it higher when they gave me the pain meds. It took it down so fast. I agree that pain is tricky. The numbers needed to treat for pain versus the numbers needed to harm for pain interventions needs to be discussed with your doctor. There is simply there's no good alternative to avoiding the important numbers that your well-being depends on. And person says, I take as little as possible. My doctor knows that. I still really want to know more about the SGB. Person, check out my other videos on SGB. If you have other questions, we can talk about them. And Gabby, so good to see you. Oh, Rebecca, thank you for this. It's perfect timing. I'm so grateful. I hope that you learned something new to better advocate for yourself. I'm trying to keep up with all your comments, by the way. Like I said, if you join the membership program, I get to see your comments more easily. Mike, let's try to answer yours. Why have insurance companies been permitted to virtually take over healthcare? This is a deep topic, Mike. They have been permitted by, I can't answer this question in one video. Suffice to say that a reductionist view that's taken up in Western medicine has allowed the influence of pharmaceuticals to be perhaps overly appreciated. I want to speak very correctly here because big pharma is very important. Insurance companies may or may not be as important, but when we submit to the human body just being a bunch of chemicals in the body, it lends itself to a treatment model where you just got to provide medications to treat those chemical abnormalities versus looking at the human being as a whole. And when you don't look at the human being as a whole, you become very transactional in medicine. And that is where insurance companies shine. Tell me if I'm wrong. Please share it in the comments below. Black Magic 617, thank you so much for being a member. I really appreciate your support. I look forward to seeing you on here more often. I have developed akathisia, says Julian Newman, from antidepressants. Now I'm sensitive to medications. I have surgery coming up. Is local anesthetic, does it have fewer side effects in general? Julian, I'm sorry that you've gone through that. Akathisias are rather rare from traditional antidepressants. I wonder if maybe some antipsychotics have not contributed to that. But you need to avoid certain classes of medications, in particular Reglan, out of the concern of it possibly worsening some of those symptoms. You want to talk to your anesthesiologist and your other doctors, certainly before your surgery. I'm wishing you the best for that. Local anesthesia tends to have fewer side effects than general anesthesia, though you are correct. PETA says, I'm a firm believer that polypharmacy is a great problem. Yes. Instead of playing good medicine, you are playing whack-a-mole with treatments and then prescribing new medications to treat the side effects of other medications. Hey, Wesley, thank you for being a Remember, your doctor wants your fourth set of blood tests. I'm sorry, Leslie. I wonder what they're looking for. I hope that your veins are easily accessed by phlebotomists. I'm hoping that the results are good. Wow, SS. That is very kind of you, and I appreciate your kind comments. I hope that you can share what you've learned with your loved ones so that they can better understand how doctors' decision-making works and hopefully advocate better so that we all get the care that we deserve. Wesley, what can high white cells mean? Wesley, white blood cell counts increase in many different conditions. The most common is some sort of infection, where your body is ramping up its combination of leukocytes and lymphocytes to take down an infection, whether it's a pneumonia or if it's a viral infection. There's a breakdown in the complete blood count that looks at the different types of white blood cells. And some of them tend to better suggest a viral etiology versus a bacterial etiology. But there's a lot of nuances there. If you have a high white blood cell count, I hope that you can find ways to lower that inflammatory burden. Can't join iOS. Well, I mean, I'm sorry, Lynn. I see you on here. I hope that you get whatever technical issue figured out, though. Suze, good to see you on here as well. Naltrexone in small doses, good for chronic pain. Kimberly, LDN or low-dose naltrexone is definitely heavily prescribed. The number needed to treat, I don't know what it is, but the number needed to harm appears to be quite high. And I don't know what just happened to me. Sorry, guys, I don't know what happened to the screen there. Meaning that if the number needed to treat is even reasonably low for a condition that's exceedingly challenging like chronic pain, a high number needed to harm suggests that it might well be worth exploring with your doctor. Let's answer a couple more questions here and trying to keep up with everyone's wonderful questions. Ricky, very good to see you. I'm happy you made it on. High creatinine tends, it is off topic, but we'll answer it, tends to suggest impaired kidney filtration or impaired kidney function. James takes 2 medications that have headaches as a side effect. I get headaches. Meloxicam and Finzi. Should I talk to my doc about an alternative? Well, James, it's up to you, but I always suggest you talk to your doctor about your medical concerns. You seem to be raising a very valid medical concern, especially because headaches, something doctors don't talk about. When people take medications to treat headaches, they can eventually lead to worse headaches, what we call medication overuse headaches. People don't talk about it, but headaches are particularly challenging, and we want to avoid medications whenever safely possible to minimize the risk of these medication overuse headaches. And Emo Surf, you're very welcome. Your comments, trying to click on here, but there's too many. You're so welcome. Why do you feel like you have no energy after coming off of these medications, Spencer? There are some hormonal changes that happen with ongoing opioid use. There's no question about that. Parts of the pituitary gland and that HPA axis can be affected, not to mention the underlying pain for which many people are taking opioids for can also potentially reduce your adrenal activity or lead to what's called adrenal fatigue. It's a little bit of a, not very biomedical, but suffice to say that if you're exhausted from pain, well, the opioids might just be a surrogate of that. Hey, you are so welcome, Miss V. And let's end with Wendy. I was on Lyrica for years. It was my miracle drug. Then my doctor took me off, changed me to gabapentin, which doesn't seem to, oh, that's not a question, Wendy. I'm sorry that you had that experience. I hope that you talked to your doctor about finding relief with the right medication for you. And, oh, Black Magic, thank you for joining and answering the akathisia question. It's actually quite more common than you think. Some patients don't get it until 2 to 3 days after medication use. It's particularly nasty for antipsychotics, but as you pointed out, some antidepressants can also have this, and it can be exceedingly challenging to reverse, and it can have complications here in the operating room. So let's I wish you all the best. If you can find ways to come off of your medications, all the better. I'm wishing you the best for your AVM tomorrow, by the way. Occlusion in AVN for a brain. I'm wishing you the best for that surgery if they use ketamine. I hope it's in a way that might give you therapeutic benefit in the long run outside the surgery itself. But the point of this conversation is that you have more power over your health than you've probably ever been told. And you can tap into that by hopefully finding ways to use medications judiciously, knowing the side effects, and knowing how you can come off of the medications. Remember, you don't want to be on destination therapies. Remember, destination therapies are medications that you take till the day that you die. You'd rather be on bridge therapies or bridge medications that get you healthy again so that your body can keep you healthy. So you take the medication until your body fixes what the problem was. Like antibiotics. You don't take antibiotics for the rest of your life. You take them until the infection begins to quiet down so your body can finish off the infection. You don't want to be stuck on those as a destination. You deserve better if there are alternatives. There aren't always, but you deserve to know if there are alternatives. And that's what I wish for all of you. If you have any other questions, leave a comment below. Share what you've learned with others. And for everyone who's joined our membership, thank you so much. I hope to see you all next time. Peace.